Good afternoon. Welcome back to Grand Rounds today. Please remember to sign the attendance record, and also please remember to fill out the program evaluations. And as I always do, I will ask you to give us any ideas in regards to future topics or future speakers. We're always appreciative. Today, I have the pleasure of introducing Dr. Joyce Black. Dr. Black received her BSN degree from Winona State, her MSN and PhD from the University of Nebraska Medical Center, where she is currently a professor in the College of Nursing. She has researched, written, and lectured extensively on the prevention and management of wounds, and she graciously has accepted our invitation to come over to Ames today and update us on deep tissue pressure injuries. Please join me in welcoming Dr. Black.
Thank you. Thank you. I never miss an opportunity to speak about pressure injuries. In fact, that's the new word as of a year ago. So if you're wondering where that term came from, it's only 13 months old. Prior to that, they were called pressure ulcers. Probably prior to that, you know them as bed sores, decubitus ulcers, those kinds of things. But this is the more recent terminology. Of course, I also appreciate coming because I get to see the last of my daughter and son-in-law stay here in Ames. They've been here for coming up on 2 years while Tim went to vet school, and Trish has worked here at Mary Greeley. So I got to see you guys in full force when the baby was born a month ago. I got to actually see the unit and see how at least your OB nurses practice. So appreciate all of that. I was glad I've never come here to see a pressure ulcer. So that's all good. So we're going to talk about deep tissue pressure ulcers. They were called deep tissue injuries till a year ago, and then we stuck the word pressure in because people confused them with all sorts of things. So interesting what you're looking at. Obviously a butt. I mean, that's pretty obvious. And I take it you're all healthcare providers because you're just flying in the food looking at a bare butt. So obviously this is not a group of attorneys I'm talking to because you wouldn't be able to eat. This is a patient who had a laparoscopic cholecystectomy and was being recovered from that, and the nurse's aide who was at her bedside was either putting her on the bedpan or about to take her off of the bedpan, and you can see the bedpan mark on this lady's butt. And that nurse's aide collapsed at the bedside of a ruptured berry aneurysm, and this patient called for help. They came in to work on that young woman for a while, and like you would expect, they pushed this lady's bed aside against the window, and she stayed there for no one quite knows how long. The purple tissue that was injured as a result of laying on that bedpan actually fully necrosed. She had a diverting colostomy done, and she eventually died of sepsis from this wound. So when you think about, holy cats, that's quite a story. Yeah, it is. It's really quite a story. But sadly, it's a common story in the deep tissue injury problem because this is a dangerous type of pressure injury in that the damage was done at the bone-muscle interface before you ever see damage to the skin. I started to recognize these problems probably 20 years ago doing clinical care, and I would see patients with what I called then purple pressure ulcers. And I knew that they were going to be bad. I would say to the family and the patient, this wound's going to get worse before it gets better. But it never really had a name. I was on the National Pressure Ulcer Advisory Panel at that time and took it to them in the mid-90s and said, we need to study this. We need to identify it. Because what was happening was lawyers were getting a hold of these cases, and they were saying, well, it was a purple stage 1 pressure ulcer, and this must have been terrible care provided by the staff of this facility because this wound within a week was completely necrotic, and is in the case that we just looked at. The patient died from the wound. So the lawyers were chomping at the bit on these cases, and I wanted NPUAP to say, no, this is not a purple pressure ulcer stage 1. This is a different phenomenon. So NPUAP, being very academic in nature, said, well, do your due diligence, Joyce, and look up and see what you can find. So this is what I found. Back in 1874, Dr. Paget actually defined something that sounded very much like what I was seeing. In fact, he said the tissue would be purple and then would slough away, and there would be exposure of muscle and bone, leaving this big cavity, and that's exactly what we were seeing. During World War II, there was a German researcher that created a pressure ulcer that was at the muscle-bone interface. That's where the pressure was applied. And he said the rate of deterioration of those wounds was malignant in their nature. So what they thought they were seeing originally was something that started as red, non-blanchable tissue and then developed a superficial wound and then got deeper over time. And both of these guys are saying this is not that phenomenon. In 1975, the orthopedist Dr. Shear defined the staging system that we used prior to DTI. And he had something in that staging system he called a closed pressure ulcer. And when you read it, the description was that there was a big wound under the skin, but you couldn't see much at the surface. But his staging system never came forward. So we lost it, and yet there was plenty of evidence that it actually was around. Of course, there were lots of other clinical records of people that I was seeing with these purple pressure ulcers, bruises over intact skin. Folks coming out of the operating room were said to have cautery burns, even though the cautery pad was not where that wound was. And all of them evolved quickly into full-thickness ulcers. This is the existing definition today of deep tissue pressure injury. And you can see the artwork done depicts a phenomenon that is visible at the surface of the skin, but the damage is all the way through. So the damage is well down into the bone-muscle interface. We know these phenomena are extremely painful because they are either a fully necrotic wound sitting under the skin or a highly ischemic wound that we just don't see. We also know that they're cold when you feel them initially, and we're actually tomorrow looking at a thermography device in Omaha to see if we can pick it up by thermography earlier than we see skin changes. We also know that the pressure that forms these is almost always very intense, and we'll see that pattern percolate through this presentation. So when you think about the history of the patient that developed these DTPIs, there is almost always exposure to high pressures in the OR, the cath lab, on the street, in their kitchen, on the kitchen floor. That story seems to hang around in almost all these cases. They do evolve rapidly within about 7 days period of time. We do have a few that don't turn into any wound at all, and we're trying to figure out what that actually is going on. We ask that as we relate this stage to the other stages, we tried in this definition to clarify that these are not stage 2s, these are not stage 4s, until we really know that, and then I'll go through some of the differentials with you. So here's the evolution of a deep tissue injury, very classic evolution. This is actually an OR-acquired deep tissue injury. This patient was tipped on the OR table more to the left in order to do surgery on the right side of the chest, and so that's what makes this kind of lopsided wound, which is one of the things that's kind of striking about these, is they don't always appear like the standard pressure injury in that they're on the sacrum. This is clearly not the sacrum, this is the buttocks. So 48 hours before that purple tissue that I labeled A1, this patient was in the operating room. So 48 hours later, the nurse will see this purple thing that looks like a bruise, and someone, of course, says, well, it must be a cautery burn, but the cautery wasn't there. The cautery is actually under the thigh. 3 days go by, and what you start to see is an epidermal blister or a lifting of the epidermis, and people see that, and they start to talk to you about skin tears. This patient has a skin tear on the butt, but they cannot relate any kind of trauma that would be associated with skin tear. This patient was placed on a low air loss mattress, kept side to side as much as we could, and by day 10, it's completely unstageable. So we probably delayed the evolutionary process a bit by putting the patient on a low air loss mattress, but it did go on to become completely full thickness. We said in the definition that there's lots of things that cause purple skin, and so here's just 3 of those examples. We certainly get purple skin when people are bruised from trauma, but we know the traumatic event. So the patient on the left was an anticoagulated woman who got up from the side of the bed and fell into the bedside stand. And so the purple tissue, which was not visible right after she fell, comes up a little bit later, is clearly linked to that. The patient in the middle is a patient who's in septic shock and critical care on high doses of Levophed. So we've pulled all the blood from the periphery, and he's got ischemic changes in the foot. I don't believe for a heartbeat that that patient was standing on his feet in septic shock and critical care. So that's plain old ischemia. And then Coumadin necrosis, you obviously have a history of a patient with a clotting problem on Coumadin. And so this one's harder to diagnose. Some of the dermatologic problems are a little bit harder. You got to do a little bit more work, but you also do not have a history of exposure to pressure on just the right buttock. So how do they start? What's the basic story? I'm going to go back into the 1950s and borrow something that Dr. Koziak from Minneapolis developed, which is this pressure curve. We don't use this curve today to describe much, but I think it helps us with DTI. So just to orient you a little bit, the y-axis here is skin pressure applied in millimeters of mercury. So he starts at 0 and goes up to 600, which of course is twice a blood pressure cuff. And then the x-axis is time. So starting at 0 going to 12 hours. And what Koziak said is if pressures are high enough, you can ulcerate muscle, you can damage muscle and eventually ulcerate skin. Now we don't see a lot of clinical examples today of 600 millimeters of mercury pressure being applied, but we do see numbers in the range of 300 millimeters of mercury pressure, particularly on the cath lab table, the MRI table, the operating table if it's not well padded. Patients who are prone for surgery would reach those numbers. And so when you look at Koziak's model, 300 millimeters of mercury matches 3 hours of time. And that's the time frame that we see pressure ulcers forming coming out of the operating room. So Koziak's model still fits, at least at this juncture. Then what we see is it takes longer to ulcerate when you drop those pressures down. And we get 200 millimeters of mercury pressure in a hospital bed. When we sit the patient up real high, we certainly get 200 millimeters of mercury pressure on bedside chairs, especially on the ischial tuberosities. So this model, the engineers tell me I shouldn't use this model, but to me it actually does explain it well. So what we're trying to figure out is how do we marry the idea that we were taught forming pressure ulcers was actually pressure applied to the skin occludes the vessels in the skin and then the skin dies, and if we continue to apply pressure, the deeper structures to the skin get increasingly ischemic and then they die, which is what we were all taught. Stage 1 becomes a 2, becomes a 3, becomes a 4 over time with continued ischemia. That was our original premise. What we've learned today from some work by Dr. Geffen in Israel is that when you apply intense enough pressure, it goes straight through the skin and right into the muscle, and it causes the muscle cells to actually break. And so this is a variant of rhabdomyolysis. If that's where your head is, you're in a good place, because that is what this is. Rhabdomyolysis being the death of muscle from extreme issues. We see it in electrocutions. We see it in assaults and with the patient is left down on the ground. We see it in motor vehicle accidents. So this is a variant of that. We know in this instance what the pressure came from, though. So Dr. Geffen is saying you get the pressures high enough, you're going to break the cell. Dr. Oomans in Amsterdam added to the story and said, but what happens to these patients who are turned from side to side in a hospital bed? And he did some experiments and said, if you turn a patient onto their side and you leave them there long enough, that tissue becomes ischemic. Then if you apply pressure to that tissue, it doesn't take long to break that tissue down. So that was his contribution. Dr. Takahashi from Japan said that pressure injuries start from pressure. So just like barometric pressure, if I push my finger into my palm, the wound that develops will either be the shape of my fingertip or the shape of the bone that I'm pushing against. So Dr. Takahashi said, yeah, pressure is the problem, but when you add shear to it, you extend the ulcer beyond its original shape. We see that in patients who have the head of the bed elevated, particularly at 45 degrees, where they're sliding down and they're shearing off their sacrums. Dan Bader from London said these things have nothing to do with moisture. There's the moisture story, the incontinence story, that risk factor isn't here. So what they all concluded, and I think it makes sense, is when you have ischemic tissue, you have a patient who's got low blood pressures, you've got a patient laying on a surface for a long time, it doesn't take much pressure to ulcerate that tissue. So depending on these variations in the theme of is it ischemia or is it pressure, you can get this whole litany of things come up. The patient on the bottom left was a bariatric patient. I'll orient you a little bit. This is the buttocks of this patient. The skin fold split both vertically and horizontally. I think you may be able to see the fecal containment device coming out here from the anus. So this is going back up to his shoulders. These fingers are holding the upper thigh. Now, the story of the patient was 700-pound man in critical care for a very, very long time. Skin stayed intact until he had a cardiac arrest. And 48 hours after the cardiac arrest, the skin on his buttocks was purple. I don't believe anybody sat on his stomach to do CPR, so I don't think pressure's in the story. I think it was straight ischemia. The patient on the upper right, that's a very classic operating room pressure ulcer that developed during coronary artery bypass. So this one is mostly pressure. If you leave the heart-lung machine out of it, I think there's some ischemia in that machine. But we know that regardless of the type of surgery, patients in surgery over 3 hours ulcerate, and this is the look of that wound. And this patient in the middle was a patient with peripheral vascular disease who was placed in a TED stocking. Her heel was elevated off the bed. She had an orthopedic procedure done. So that's a patient who had baseline ischemia, and then we added TED stockings to it. TED stockings, by the package insert, are not supposed to be used on patients with vascular disease, but of course we get them anyway. So those are, that's how it starts. So what goes on from there? I think the best corollary to deep tissue pressure injury is that of stroke and MI and burns, where we have a zone of infarct where the tissue is dead. We're not going to get that tissue back. Surrounded by zones of ischemia and injury that are actually ischemic tissue that can be recovered if we offload that patient. So if you're familiar, this is obviously the pathology of the MI. If you're familiar with those pathologies, this is the same thing. It's just in muscle, skeletal muscle, instead of myocardial tissue. We know that tissues survive ischemia for different periods of time. We know that skeletal muscle can survive ischemia for somewhere around 6 hours, and at that point, the available oxygen within the muscle cells is gone. We know that skin can survive ischemia for quite a while. When I did burn care, we used to take skin grafts that were harvested in the operating room, and we kept them in the refrigerator on a normal saline gauze for 2 weeks, and that skin was still viable to be put on that patient. I don't know the ischemic time of fat. I couldn't find it in any literature. It seems like the ischemic time for my fat must be decades because I cannot get rid of it. It just hangs around. If I could get rid of it by beating it up, I would do that, but it doesn't seem to work. The other pathophysiology is that of reperfusion. So looking at this model of a vessel, pressure is applied here to the vessel, just like you're sitting now. If you're sitting on your ischial tuberosities, if you're sitting erect, so there's pressure being applied. So the vessel, the inflow is stopped because of the pressure, and we get openings in the capillary membrane. And so some of the cell products, cell byproducts, cells themselves are able to escape into the tissue around it, into the interstitial spaces. And then on the outflow side, there is no blood flow, so the red blood cells stack up like coins and little microthrombi form. So this is the no flow step. When we release those pressures, now we have a head of pressure coming down because we've opened it up, and that allows a greater amount of some of the cytokines, some of the oxygen-free radicals to escape through these cell wall holes that have been formed in the lining of the vessel. So the idea, again, is similar to MI and stroke and burn. When we talk about ischemic tissue and we talk about reperfusion injury, those of you that work in ER now know that when we use the clot-busting drugs to open up the coronary vessels, we get a huge run of PVCs from the release of all the lactic acid in that ischemic tissue. So this is that same concept that we know exists in the deep tissue injury story. So now, putting all this together, the initial injury comes from pressure. We get some oxygen-free radical release. They're sitting there until we reperfuse that tissue. We know that the ischemic tissue becomes quite stiff, and it makes it more difficult for it to be responsive to the incoming arterial flow. And then if we put shear injury on top of that, we just make the story worse. So here's our case of exactly that. This is an obese man who was admitted to a hospital with a small bowel obstruction on Friday. He was NPO over the weekend. The nurses documented that they turned him every 2 hours all weekend long. On Monday morning, the wound team came to see him, and one of the nurses wrote that this man was too big to be turned in his bed. Well, I don't think he got too big on Monday. I think he was probably too big all weekend. And at his weight, he compressed the mattress, and he was actually laying on the frame of the bed. He then got respiratory distress. They moved him into critical care, and they put him on a kinetic bed, which is one that constantly moves him. When they put him on the bed, they described him as having a purple butt from trochanter to trochanter. So he had a deep tissue injury that formed from not being able to move on his existing bed. Then he was put in a kinetic bed, so now he's basically shearing off his butt. And this is back in the days of Polaroids, so that's why this picture is so weird. It's got the slice down the middle. His wound went from trochanter to trochanter. This is post-debridement. He lost all the skin of the buttocks. He lost his gluteal muscles. They had to resect his sciatic nerves, had a diverting colostomy. The hospital was out several millions of dollars because this man was in his mid-40s when this happened, worked as an auto mechanic, so he could not return to work because he couldn't stand without the use of walkers and braces, and was the father of 4 children. So lots and lots of money went on that particular case. Epidemiology, DTI is being studied now, starting to show up as part of NDNQI, if you guys report to them. Hill-Rom data does pick up deep tissue injuries. We're seeing more and more of them. This is some older data, but back in 2010, when we first started to collect this, we were seeing that probably 13% of facility-acquired ulcers were deep tissue injuries, and most commonly in the ICUs and in the LTACs is where they were showing up. Kathy Van Gilder went on to talk about the fact that they were more common than 3s and 4s. Well, that's because they probably are the beginning of 3s and 4s, so there'd be more of the beginning ulcer. Some of them will be rescued, but she finds 41% are on the heel and about the same amount on the sacrum and the buttocks. So when we look at how pressure is distributed, we can see that this is a normal weight patient. This is a patient flat on the bed. So we've got pressures on the occiput, the shoulder blades, the buttocks, not the sacrum, and the heels. Here's an obese patient. Roughly the same distribution, except there's a little bit more weight because of the size of the chest. Still on the occiput, the heels. And the majority of stretching across the buttocks themselves rather than on the sacrum. And that's actually where we see pressure ulcers form in patients who are flat. When they lay flat on the OR table, flat on MRI tables. When their head of the bed is elevated, they ulcerate their sacrum. But when they're flat, they ulcerate their buttocks. These are some scans in the operating room showing us exactly the same distribution of pressure in the OR. Depending on which way the patient's tipped on the table, this patient's perfectly flat, but you see that distribution of pressure not on the sacrum, but on the buttocks tissue themselves. These are patients in lithotomy position. You can see that when we lift the legs up and suspend them up in the stirrups, more weight is dropped onto the buttocks. So this is the look of a DTI of the buttocks. This is an operating required DTI. You can see the distribution right on the buttocks, so it makes sense. This patient was supine on the table at the time that ulcer happened. This patient had coronary bypass procedure done. This picture is overexposed. It looks like it's covered with zinc oxide, but it's actually poor camera. So here's how it started, purple, then it goes on into a blistering state, and then it becomes necrotic within 7 days of time. The difficulty with some of these surgically acquired DTI is it's difficult to get the patient off of their butt. because it's common to take care of these patients in a supine or semi-Fowler's position, and difficult to convince the patient even to turn on their side. We had some hospital remodeling done a few years ago, and even though we wanted the television up high, like in the ceiling, so it wouldn't be stolen, the engineers put the television on the wall where you can only see it if the head of the bed's elevated 30 degrees. And so now all of our patients want to spend the majority of their time on their back with the head of the bed elevated to see the blasted TV. And so when we tell them you need to get on your side to get off of this injured tissue, we have to turn the bed at an angle. Would have been nice had we had some more clinical input into that design. So one of the other things I did as part of my venture with NPUAP is tried to get a sense of how they start, what the timing of this thing is. So what I did was looked at 82 cases of patients who sued their providers because they had this rapidly evolving pressure ulcer at that time. And what I found was that 48 hours prior to the tissue turning purple, there was this period of what I called confinement. And I use that word deliberately because it was a patient positioned on a surface from which they could not move. Had they been able to, had they been conscious, not paralyzed, not sedated, not anesthetized, they would have gotten off of it because these things are too painful. If you know it's happening, you would move. So what I found was this period of confinement happened 48 hours before the skin turned purple and about 72 hours before the skin blistered. In my group that I looked at, I had people from the age of 24 to 98. Today I've seen DTI in neonates and seen DTI in people over 100. So this is not, again, not the classic pressure sore, bed sore, decubitus ulcer that occurs in elderly, contractured, incontinent people. This occurs in anybody who's exposed to high pressures, which is different because our headset's not used to thinking about a 24-year-old or a neonate having a deep tissue injury. Mona Baharastani did the same work at the same time as I did, and she pulled 200 cases. Mona saw them after they were admitted. The advantage I had is I had the records before they were admitted. Mona saw them when they were admitted to the wound service. She saw DTI in patients with pneumonia, sepsis, and failure to thrive. She saw the same pattern of deterioration, though, in that they started out with intact purple skin, and within 7 days, 46% of them were necrotic. And this is being given good wound care. So this is sort of the story of the horses out of the barn by the time you see purple tissue, because 48 hours has lapsed from the time the pressure was applied. Little bit of work done in North Carolina. They're starting now by 2011 to see some improved outcomes. Only 28% of them evolved into stage 3s and 4s. But the interesting thing this group added to the natural history was that they found that 65% of these patients were on anticoagulants. Now, in 2011, we were past just Coumadin and heparin. We had Lovenox in the mix by then. Today, we have a whole slug of other anticoagulants. I don't know what the role is in anticoagulation and the development of deep tissue pressure injury, but my suspicion is there's some connection here because we didn't see them at the numbers 20 years ago that we're seeing today. So I think there's something that's driving that. The most recent natural history was done by Rhonda Sullivan down in Jacksonville, and she has fewer deteriorating, only 9% of them deteriorating. She's not reporting on anticoagulation. She's reporting on a high number of them going to surgery in the past 7 days. And of course, you don't take anticoagulant patients, well, you don't take them to surgery very easily. You've got to have the blood bank on notice if you take them to surgery. This is a patient we had, went home from the hospital after a fractured hip repair, and his wife said that he did nothing but sit in the recliner. The only time he would get out of the recliner was to go to the bathroom. She brought him his food, she brought him his meds, and only when physical therapy came did he ambulate. So he sat in the recliner, and he's got a pretty nice recliner butt there. So he comes into the hospital septic. He was so septic, anesthesia wouldn't take him to surgery. So he was debrided at the bedside just to get rid of obviously the nidus of infection. It was the only source of infection in the guy. Here he is in the operating room just before the final debridement is done. And you can see that's not a vac sponge. That's ongoing necrosis of the muscle and, of course, wound sepsis. You can see the condition. This is him in the OR when he's had that initial debridement. There's gas in the wound. The wound is extensive. He went on to heal, and he was admitted to rehab the next time because we didn't want somebody waiting on him hand and foot. The diagnosis of DTI is difficult because you've got that 48-hour lapse in time, and there's lots of things that cause tissue to be purple besides pressure, so people call them all sorts of things. We had the opposite happen when we introduced DTI to our hospital. It's been a while ago. The wound team got called for port wine stains that were present since birth, traumatic injuries where we knew the patient had fallen. So we were happy to have the nurses telling us about purple anything. We just had a lot of false negatives or false positives there. Some ultrasound being done. This is true ultrasound, so you need an ultrasonographer, but they are seeing areas of reduced echo in deep tissue injured cases. We also see elevated CPK levels. The problem is we can't tell that it's that deep tissue injury as much as it could be any number of things. And as I said, tomorrow we're starting this little venture with thermography. This is some early work done with thermography. And thermography is able to pick up that cold tissue from lack of blood flow. So we're hoping that we can get a better picture of deep tissue injury before that 48-hour window. I wish I could give you lots and lots about the prevention of deep tissue injury. I can't. Whatever you're doing now to prevent pressure injuries will prevent deep tissue injuries because they should be the same thing. We know that there are a couple of hospitals who are using non-contact, low-frequency ultrasound after long operating room cases in an effort to try to reduce the risk of evolution of DTPI. I don't have their data, but they've been doing it for, it's getting close to a year, so I would think they'd have data. So the best thing I can tell you is to be aware of the high-risk patient. The clinical profile of risk is this period of confinement, long OR cases, interventional radiology, emergency rooms, people found down at the scene. What we ask our paramedics is when they bring people in that are found down at the scene, we ask them what position the patient was found in down at the scene. And that way we are able to attribute later deep tissue injury in those same body parts to their original position at the scene of the accident or the house, rather than something that we did, because we'd like to not be clipped for these things as being hospital-acquired DTI. I don't know the effect of all the anticoagulation. There's been some work done to try to pull it out, but I don't know that piece. So presentation, deep tissue injury occurs on tissue subjected to pressure. So it's not the places that you're used to. It's not going to always be the sacrum and heels. It's going to be whatever tissue was exposed to pressure. This first patient was a patient who went into critical care, septic, and was placed on a ventilator, so had a bed elevated. And this upside-down heart shape is a very classic presentation of DTI from the head of the bed being elevated at 30 degrees. So the question would be, well, could we have done anything different 48 hours ago when this patient came in septic, or was he so septic that we were having a hard time keeping his pressures elevated? This second patient is a patient who had a Whipple done. And so this was the original DTI, this necrotic tissue on the buttocks cheeks. And then he got septic after surgery, was placed in critical care, and this is the later DTI from the head of the bed being elevated. If the patient sits erect, such as a para or a quad, they will develop DTI on the ischium. We also see DTI under medical devices, so don't be surprised. The source of pressure can be any number of things. It's difficult to find that injured tissue in darkly pigmented patients. This is a black patient, obviously, who was in critical care. This upside down heart shape to me looks exactly like the other one did in the man on the previous slide when we were looking at a septic patient in ICU. The blistering is fairly easy, I think, to see. You can see rippled skin throughout it, and here's that epidermal lift that we've been looking at in some of those other cases. tissue underneath here at the bottom, though, is dark. So this is not a stage 2 pressure injury because a stage 2 pressure injury does not have a purple wound bed. When the nurses saw this patient's skin, they called it a skin tear. And because, I think, because you can kind of see the remnants of the skin sitting here, and it looks like skin tear, but there was no history of trauma that would account for that. And of course, you got blistering throughout the rest of the skin. Some differential diagnoses that I think are important to at least think about. One is traumatic events. So here's our patient again that fell into the bedside stand. This is a patient was in Sioux Falls, South Dakota, who was traveling at very high speeds in the back of a pickup truck, flew out of the back of the pickup truck, had an open book pelvic fracture with massive hematoma sitting along the backside. She sloughed all the tissue on top of that hematoma and sued the hospital for what the claim was that this was deep tissue injury. So just to orient you, you're looking at the side of her hip. This is her gown, so her chest is up here to the upper left. This is her thigh. I think you can maybe see the fingers of the person pulling her over. So this would be an unusual location for deep tissue injury, because how would you get pressure on that lateral butt? And so when I was sent this case to look at as an expert witness, I said, please send me the CT scans. And when they sent me the CT, I could see the hematoma before it was drained. The hematoma sits in there and basically separates the blood flow from reaching the skin, and the skin dies on top of it. Orthopedists call this a Morel-Lavallée lesion. And so I called it that, and the hospital, she lost all the skin of her buttocks, but I don't believe she had a case against the hospital because of the existing hematoma. And this is just another hematoma, same story. You've got a history of trauma. Ischemia also leads to purple tissue. So here's the guy we looked at initially, ischemic feet. This is a patient who has venous congestion. We knew about this wound here. When I went in to see the guy, this was the purple tissue. And when I turned him on his side, I had by then put my camera outside. He was in isolation. When I got back in, all that purple tissue was gone. So it was not, had nothing to do with pressure. It was just venous congestion. We are starting to see again something called a Kennedy terminal ulcer. At least it's back in vogue to be calling them Kennedy terminal ulcers. This is a patient we had at end of life, and you can see the purple tissue forming there. The Kennedy terminal ulcer to me has to be associated with a terminally ill patient. You can't just call everything the Kennedy terminal ulcer and hope that they sort of disappear from your worry box. And this is a patient who injected cocaine, not into the thigh, into the arm, but because of the massive vasoconstrictive ability of cocaine, the tissues died. And then there's some differentials that include the dermatological problems. Here's Coumadin necrosis again. Lymphedema can look purple, but it's not anywhere exposed to pressure. Calciphylaxis is a rapidly necrosing tissue, but it's not. This is obviously the leg of a patient. You'd have to say, what pressure source led to that wound? I mean, was it a toy? What was he laying on that would lead to that? So a little bit of background work should fill it in. And then even pyoderma has a bit of a purple tissue, but it does not have anything to do with pressure. Chris Berkey, one of the nurse practitioners in our wound clinic, has been taking care of people that are wheelchair dependent or stay in recliners a lot. And she has found this condition that she's labeled a chronic friction injury. What Chris is teaching all of us is that these are patients who slide across a slide board or slide down in their wheelchair or recliner and repeatedly injure their tissue. The tissue becomes purple, like you see, becomes purple in areas of the body that would get deep tissue injury. But there's no exposure to pressure in the story. When you ask how long this has been there, this patient, it had been there for 2 years. Deep tissue injury isn't going to hang around for 2 years. It's going to become necrotic much sooner than that. And so this needs to be added to our differential list for a slightly different reason. As you palpate the tissue, it's hard. It feels to me like calluses, which would also not be typical in DTI. So the management of DTI, we don't have many options here. We need to relieve the pressure. They need to be offloaded. So that means they need to turn side to side. Whatever support surface you've got the patient on, if it's not better than 4 inches of foam. We need to move them up. And then to low air loss, we need to get something that's got better pressure relief there. If this is DTPI on the heels, they need to go in boots. I don't know. I didn't see how good your pillows were when I was on your OB unit, but our pillows collapse under the weight of your hand. And so we put them under the head of a patient and we fold them up and roll them up and crunch them together. So if you believe that you can put a pillow under someone's calf and the heel will stay off the bed, you must have better pillows than we have. Because within 5 minutes, the weight of the leg has gone all the way through the pillow and the heel's on the bed again. So the heel needs to go in a boot. You need to make sure they've got good perfusion, because that's our only option, is to sweep out the dead tissue and try to get those zones of infarct and injury to recover. We're not going to, the zones of injury and ischemia. We're never going to get the zone of infarct back, but we'd like to stop the extensiveness of the wound. There's some beginning evidence for the benefit of non-contact ultrasound. Jeremy Honecker has done some of this research where he used non-contact ultrasound on patients with deep tissue pressure injury and found that they didn't go on to become these huge full-thickness ulcers. There's also some work done by Dr. Sonata in the concept of vibration. And the way that this non-contact ultrasound works is it creates a vibration in the tissue, which causes vasodilation in the tissue, and also helps sweep out some of the oxygen-free radicals with all the additional blood. So it makes sense that it would work. Honecker's research is better than Sonata's because he's actually using actual patients. There is a drug on the market that's a superficial vasodilator called Vaselex. People talk about it. They say it works. I have no data to offer you on it. People have used topical nitroglycerin, try to open up the tissue, but the damage is in the muscle. So you have to think about, how can I get a vasodilator to reach that level? I wish there were just a ton of evidence on hyperbaric oxygen, because it seems like that would be the perfect match for this disease. But right now it's not an indication for hyperbaric, so I haven't got any data. I can tell you that people who use hyperbaric oxygen to treat the other illness the patient has, when they also have DTI, talk about great results. But I haven't got a case series to give you. Here's Jeremy Honecker's work. He looked at 127 DTIs. This was a retrospective control group and then a prospective treatment group. So he had 63 just standard of care and 64 with standard of care and non-contact low-frequency ultrasound. He got good resolution of those. Whoops, I thought I had his slide in here. I guess I do not. He got good resolution of those deep tissue injuries. Sorry about that. I thought I had his next slide. So one of the things, of course, that hospitals are concerned about is, did this deep tissue injury start before the patient came in? Was it actually present on admission? And can we label it as present on admission? Remember, there's that 48-hour window. So if this patient is on the kitchen floor Saturday afternoon and nobody finds her till Sunday morning when she doesn't come to church, that wound actually started Saturday afternoon. So you get her in the hospital Sunday afternoon, her skin's intact Sunday afternoon. Monday afternoon, her skin is purple. So now it appears that it started on the hospital's watch. Well, it did not. And the federal government completely understands this. The problem hospitals have is they have nurses do an admission skin assessment, and they don't often repeat it the second day. And so if you repeat it the second day, you are absolutely able to classify this thing as present on admission, even though you couldn't see it. So you need to do a root cause analysis. You need to figure out, when did this thing actually start? And what I want you to look at, because of the timing of DTI, is I want you to look at the events 48 to 72 hours before the skin was purple and see if you can figure out when and where that period of confinement was. If you didn't own the patient at that time, it's not your pressure injury. It was present on admission. You need to do both the timing and the location. So if 48 hours ago this patient was in surgery and now I see pressure injuries on the buttocks cheeks and she was supine, those two things match. Obviously, root cause analysis, you want to make sure, if you did own the patient 48 hours ago, were you doing the right things? Or could you not have done the right things? Maybe there was no way for that patient to have been moved off of that body part. You take the root cause analysis and you pool them all together and you start to look for common themes called common cause analysis. So what we found out is that one of our operating rooms had a higher incidence of DTI than any other one. So we trailed on down to the OR to look at how bad that mattress was. I think we bought that mattress with the Hill-Burton Act of '68. It was really bad, and the patients can't tell you. They're anesthetized, and you as the OR team don't lay on the OR mattress, so you don't know how bad it is. And so that's what you do with the group. You try to figure out where is our problem. If it's sporadic, it's going to be harder, but eventually you'll be able, I think, to pull those cases together. And then you can start to teach your staff about this theme that you're starting to see. It's kind of hard to chase them down one at a time. So here's a little bit of a repeat of the same story. So DTI presents about 48 hours after the insult. The epidermal blistering in another 24 to 48 hours. And it's important to get that timing because you can then figure out when it started. If you own the patient, could you change positions? Was that patient movable, or was their pressure too low to be moved, or were we trying to get rid of some atrial fib and they were on the interventional radiology table during that period of time? You need to pull the timing together with the location of the wound because you'll be able to figure out where that patient was. We are seeing a fair number of DTIs occurring during cases that are prone in the OR. They're easy to see because they're on the face and the anterior surface. So we can pull those cases together pretty well. The rest of this is where you would think pressure would be applied. So if the patient's supine, it's on the butt cheeks if they have a butt. If they don't, it's going to be on the bony structure of the pelvis. If they're head of bed elevated, it's going to be on the sacrum. If they're sitting erect, it's going to be on the ischial tuberosities. So these are two patients who went to the OR, and you can see the ulcers are on the cheeks of the buttocks. Sacrum is actually up here. And so when you look at these, you're going to think, well, this patient was flat. I can tell you the difficulty you're going to have is not everybody has the option of a drop-down menu with the word buttocks, or doesn't put buttocks in the record. And so they will call these sacral ulcers. And so when you hear that, you think, well, the head of the bed must have been elevated then, so let's look at that story. And photographs are amazingly helpful because they can help you figure out what the true story was. I have a case I'm working on now in Texas where the patient developed DTI, and I don't have a photograph of it. So the chart says deep tissue injury of the sacrum. And so I'm looking through the chart trying to figure out what happened to this patient and when did he have his head of bed elevated and they couldn't turn him or he wouldn't turn, or what's the story? Well, the attorney said, I found a photograph of the wound. I'm sending it to you. When I got the photograph of the wound, it was not on his sacrum at all. It was on his right buttocks. He had a right total knee done. So I said, well, wait, that changes the game a little bit here, because now I can see what actually happened to this guy. Probably started in the OR. And so I was much better able to defend the hospital. I was struggling a bit with the pressure ulcer on the sacrum. Here's the sacral pressure ulcers. Classic upside down heart-shaped position to these things. These are the location when the head of the bed is up 30 to 45 degrees. So what we're seeing today is deep tissue pressure injury in intensive care. And these are patients that tend to be more ischemic, so they ulcerate more quickly. The time to ulcerate on standard hospital beds isn't fully understood. I wish I could say that they can only be in one position for 4 hours, but I don't have any data on that. Even in our ICU cases, we still see about that lapse in time, 24 to 48 hours. I think they ulcerate a little bit earlier because these patients are ischemic on top of pressure. So there's the classic ICU one. The other one we're seeing today is deep tissue injury from people being placed in bedside chairs. We've talked about the OR, so I think we can skip that one. That is one of our patients. The wound team was asked to see this guy for venous leg ulcers. And this is how we found him when we got into the room. So this guy is perched on the edge of the chair. His medical history came in for small bowel obstruction. You can see he's still pretty distended. So he can't bend it very well, so he can't get to the back of the chair because he can't bend over his stomach. He's sitting on the edge of the chair, which of course is dangerous from a fall risk. And the chair cushion that was ordered for him is down here. He's got his feet on it. Now, I have to tell you the backstory to this. My other daughter, of course, my one daughter here is a nurse, but my other daughter's a lawyer. And Katie wanted to know where the risk was coming from for surgical site infections in orthopedic cases. So I said, well, let's go walk around. So we're walking through the hospital, and she sees patients with their feet elevated on trash cans. They took the footstools away because they were a trip hazard. So how do we elevate the legs of a patient when we don't have recliners with leg things? So they turn the trash can on its side or upside down. They take the trash out, but they're still using the trash can. And of course, Katie says, Mom, you can't put people's surgical legs on trash cans. Well, but we got to elevate them on something, Katie. And you notice the trash isn't there. And she said, yeah, but the families are saying they put my dad's leg on a trash can. It's no wonder he got an infection. There's our problem. So we tried to change practice by getting rid of the trash cans, even though this guy didn't have a total knee, but by getting rid of the trash cans, and we missed the mark. We ended up with people sitting with their feet on the chair cushions. I don't know if anybody's here from the OR, but I want you to tell me if you can figure out what happened in this story. 66-year-old guy, pretty good size, 252 pounds. He has a surgical repair of the ureter system to both sides. It was done in a supine position through a midline abdominal incision. You can see he's on the OR table 1 minute short of 4 hours, never hypotensive, and then went to the PACU for a couple hours on top of that, so you know that he's sitting on his back in PACU. 2 days after surgery, his one buttock is peeling, and this is a week later. So what happened? If this is operating room acquired, how did he only end up, he was supine, so why not on both butt cheeks? I presented this case here in Ames in March to an OR surgery group. They nailed it. Because I was sent this case, another lawyer case, I was sent this case by a lawyer in Phoenix who said, this was hospital-acquired deep tissue injury. I want to sue them because he ends up with this big wound. And so I looked at it and said, well, yeah, it happened in the hospital, but I think it happened in the OR, but I don't know how. So I come here to Ames. I show the nurses, and they said they planed him. Of course, I'm not an OR nurse, so I don't know what that word means. So I said, what do you mean they planed him? And she said, well, he started out supine, but in order to reach through his big abdomen to the left side of his kidney, they had to tip the table to the right side so the surgeon could reach his left side. Because the surgeon isn't ambidextrous enough to go around to the left side, so they tipped the guy on the table, which meant all his weight landed on his right butt cheek. So I called the attorney and said, I can't help you with this case because I don't think, he needed the surgery. Unless you can find a right-handed and a left-handed surgeon, he's got who he's got, and I don't know how it was preventable. Well, she was not happy with me, but I took the case anyway. Oh, I forgot. Here's that case. This is the guy who had a total knee done, and initially the staff told me, or the chart told me, the staff recorded, that it was on the sacrum. That's not sacrum, that's butt. And so this was another one where I was able to say, no, I don't think so. This one was a longer period of time and developing, but I think it's because he's 400 pounds of body mass. So I think what we've got in the DTI story is patients at high amounts of pressure. Pressures are high enough. They're not long-lasting pressures, but they're high enough that they're actually killing the muscle. And then the blood vessels that come up through the muscle belly that feed the skin are killed. And remember, skin lives longer than muscle, so it takes a while for that skin to die. On this side, pretty classic, regular old non-blanchable stage 1 ulcer. So there are two extremes to this story, and I think we see them both. Deep tissue injury is a very dangerous form of pressure ulcers because you've got a window of time in which nobody knows that they're there, and then once they form, they evolve rapidly into full-thickness wounds. So high risk of litigation. I didn't talk about that, but I think you can figure that out from the number of lawyers that get chasing down these kinds of wounds. So I think I've got a couple minutes for questions. I appreciate you spending your lunch hour with me. I know you've got patients to go back to, so you will not insult me in the least if you need to get up and leave. And if you need to contact me, I know my email was provided to the folks who organized this, if you want to do it that way. Thank you for spending your lunch hour with me. I appreciate the opportunity to come and see Lincoln and do this talk for you guys too. Thanks. How many of these have you seen? Are you seeing a bunch? We don't see them every day, but when we get them, they seem to be severe. The wound team, are you guys the wound team? You seeing these things? Yeah. I can't imagine you're not. One of the difficulties we had is getting people to see how serious they were. Because some of these patients show up with purple skin or blistered skin and then they're discharged. And so the staff don't see the evolutionary steps that you guys do because you follow them all the way through. And so we had to post some ugly pictures for a while to get people to go, ooh, this is, I mean, you know, kind of the same idea as, well, the incision was just a little bit red when the patient left. So you didn't see that it became a full-blown, surgical site infection. So. Yep, right back where you are. I think she's got the microphone standing right there. Yep, thank you.
Is there anything they could do that be proactive when they come out of surgery to help?
Oh, that's a fabulous question. I'll back you up a little bit. We are starting to see a benefit of padding high-risk body areas with, you guys, I think, have these dressings in-house. They're called Mepilex. We have some pretty good data on that dressing in particular, reducing the pressures applied to the tissue and reducing DTI in surgery and in just general care patients. The prevention, this one's hard. The prevention is to get the patient off of the body part exposed to pressure. So if you have a surgical patient come back and they were supine for the case, the ideal position would be anything but supine. And yet that's exactly the way they're positioned. So they end up continuing to lay on the same body part. It's been around for a long time that people have said, if you were supine for the case, how about we turn you on your right side for a while and get the pressure off of your back? And yet patients don't want to do it, and nurses are a bit uncomfortable with patients when we can't see their airways. And but that's really the trick. Like I said, that one group is using non-contact ultrasound to try to, get the tissue more healthy when they leave the OR, but I don't have their data. Well, very good. Thank you. I'll be here for a couple minutes.